And this is here the paper published in American Journal by Voigtland et al. They have been looking at liver enzymes with antidepressants with different ones. And what they say here is all antidepressants can induce hepatotoxicity, especially in elderly patients and those with polypharmacy. And then they say maybe with a greater risk of hepatotoxicity, hyperniacin, nifazodone, phenazine, imipramine, amitriptyline, duloxetine, bupropion, trazodone, tianeptine, and ecomenadine. And those with a lower chance are probably citalopram, escitalopram, paroxetine, and fluoxetine. So in fact, you can have it with all of them. And this is how things go. Society and regulatory becomes more and more controlling, and so they push you always to be more and more cautious. And from the moment there's something, everybody. You remember when it was that was a kind of beginning, especially in adolescents, treating with antidepressants, that you could have in the first week or two a slight increase in suicidal ideation, never in suicide, but in suicidal ideation. That was found mainly in a paroxetine database, but it became a black box warning for all antidepressants. So with agomelatine you should be cautious, but don't think you should not be cautious with the other ones. Let me take you, this was just a standard way of looking at efficacy with an antidepressant. Let us take it a little bit further, because we already discussed with some of you before the symposium. We discussed, yeah, okay, psychosis, this is rather clear-cut as a diagnostic entity, but depression, difficult, vague. Where does depression really start and where does it end? And if you see here, this is a slide just showing that depression is associated with so many other things. Having a pure case, if I see my residents in training, I supervise the outpatient clinic, and they come, and they are in the beginning sometimes pretty disappointed because they learn the text with all these clear-cut diagnostic entities, and then they see patients and they say, it's a bit of that, and it's a bit of that, and it's comorbid, and etc. It's never a clear-cut image. And this is what you see, and this is in fact, I think it's important, because each of these ones, anxiety, somatic symptoms, positive affective cognitive functioning, are very important. And it's at the same time an illustration of 30 years of marketing with antidepressants, because it all depends where you put your light on. And for those having a longer history in psychiatry, the SSRIs, they focused a lot on anxiety. Have you ever been thinking why paroxetine is called an antidepressant? It has at least 5 indications in anxiety disorders and 1 in depression, but we call it an antidepressant. And then came duloxetine, painful somatic symptoms. And with agomelatine, there's a lot of emphasis on positive affect. And what do you see here as a difference? I put positive affect in depression, because it's a core criterion of depression, anhedonia. And then you are going to have, in some time, vortioxetine, another new drug, and that's focusing on cognitive function. So there's a lot of sidewalks, associated symptoms with depression that are very important. Let me come back to the definition. And I said, well, depressed mood, excess of negative affect, diminished interest of pleasure, absence of positive affect. And these are the 2 core criteria of depression. And if you look at Clark and Watson's tripartite model of anxiety and depression, these authors suggest that in fact anhedonia is the most specific one for depression. Because negative affectivity, you find that in anxiety and in depression. And you can have somebody with severe generalized anxiety disorder, but at some moments this person is still able to enjoy things. You cannot find a very severe depression still enjoying things. So anhedonia is maybe the most specific one. And we are not looking at it. Because we take it for granted that if we decrease the negative, that automatically the positive will increase. And that's simply not true. All research shows that in fact the correlation between change in negative affect and change in positive affect usually are correlation coefficients of something like 0.40, which means 0.40 times 0.40, that only about 16% of it is correlated, and the rest not. So it's mainly independent few more words, because we don't talk about it, anhedonia criteria. Lack of interest, this is already a problem if I come back to this slide. This is already a problem with the DSM, because diminished interest in pleasurable things and diminished pleasure from pleasurable things, that's not the same. That's not the same. Not biologically and not psychologically. Because indeed, you have at least, if you talk about anhedonia, you have at least two dimensions in it, and maybe a third. The first one is what is called, that is interest in. That is appetitive, anticipatory, motivational function. I came to Saudi Arabia and I was appetitive. I wanted to come. Consummatory, experiential function, that is liking, taking pleasure from it. Now I'm here, I'm taking pleasure of being here. But it's not the same. So that's the two. And one thing is probably more linked to dopamine, liking is probably more linked to the opioid system. And sometimes, in some more recent literature, they even talk about this third dimension in anhedonia. And that's what they call, I don't like the word, but they call it post-consummatory function of hedonia. And that is, if you are full of interest, full of wanting, and you're full of liking, these people are usually well surrounded, have a lot of friends. And that is protective on days that things go a little bit worse. So that's broad and built theory, that if you're full of positive affect, you're usually more in contact with others, and that's protective for when things go wrong. And maybe it's important that we have another look of looking at depression, not only excess of negative, but also the lack of positive. You could say mental health is in fact a balance between negative and positive affects. There's even research going on, I don't have time to go into detail on it. For example, that what is very different in depressed patients from normal people is if we all have, human existence has its negative points, has its negative emotions, you can't escape them. But depressed, once you have something negative, depressed patients stick to that much longer than healthy persons. They stick to it, and it takes much longer before they again can experience something positive. So it's also in the dynamics of positive and negative that things are different in depressed patients versus healthy. Negative emotions, anxiety, depression, irritability, shame, guilt, etc. They narrow your attention. If you're full of negative emotions, it is withdrawal. It narrows your attention and you withdraw. Positive emotions, on the other hand, they make your thoughts more flexible, more creative, more integrative, and result in approach behavior. And in the beginning, when I gave these talks on positive affect, I sometimes got a question from the audience saying, yeah, but be careful with too much positive affect and you're going to have a hypomanic or a manic patient. This is not true. I went back into the literature and I found some other theories, and I think very interesting is there is in positive affect even 3 subgroups of positive affect. The first group is achievement-based. I feel activated, I feel energetic, I feel lively, I feel active. The drive, the pleasure of achieving things. We all agree that in manic patients this is exaggerated. But then you have also a second group of positive emotion is affiliative-based. I feel safe. I feel secure. I feel warmly surrounded. And you have then the third group, which is then more on my own. This is still linked to people. This is on your own, the well-being. Soothing and calming, contentment. I feel peaceful. I feel relaxed. I feel zen. So these are 3 subgroups, and you probably agree with me that in a manic patient, this is not present. This is excessive, and the last one is certainly not present. So it is not so simple saying too much positive affect is hypomania or mania. That's not true. Is this important? Is it important because it's a core criterion of depression? Lack of positive affect, anhedonia? Is it important because I show you some theories that say that it is important? Or is it important because patients think it's important? And again, we're doing quite a lot of research on that. And we started, in fact, from